And we're back here at the World Healthcare Congress in Washington, D.C. Thanks for joining us. I'm Mabel, Jong, and in our studio we have Allison Hess, Director, Wellness Programs at Geisinger Health Plan. Allison, thanks so much for your time today. Well, at this conference, we're talking a lot about social determinants of health, and you take that a step further by addressing diabetes. Tell me about the program and how you're addressing certain needs of people who are in this category that have that diabetes.
Sure. So we looked a lot at our data that we had as an organization, our clinical data, and realized that there was an increased prevalence of type 2 diabetes in our patient population, but there was also a growing rate of diabetes prevalence nationally. So by 2050, 1 in 3 Americans will have type 2 diabetes. It's one of our highest costs as far as care and spend. And so what we wanted to do was we wanted to look at some innovative ways that we could combat type 2 diabetes. And we already had a very robust clinical resource structure around it, but we felt that there was something missing because we really wanted to look at some underlying pieces that were maybe driving the trend that we were seeing. And as we started to do some additional research, we really recognized a bidirectional relationship between food insecurity and type 2 diabetes. And where when you look at the data, 1 in 8 Americans is food insecure. For our patients with diabetes, it's about 1 in 4 are food insecure. And when we looked at the different counties within our population, we had some very high rates of food insecurity and some very high rates of type 2 diabetes in counties within our coverage area. And so that's what led us to think about how do we solve for food insecurity so that we can potentially then get at the type 2 diabetes issue by addressing that social determinant. And that's really why we went down the path of the fresh food pharmacy program.
Okay, so addressing food insecurity specifically, this is when people don't know where their next meal is coming from.
Correct.
Is that correct?
Yeah.
And you said 1 in 8 people have this. How are you finding these folks and learning that this is the case for them?
Yeah, so there's a couple different ways we look at the data. We look at what's available through state or national databases, but we've actually embedded into our electronic medical record 2 questions, so the approved questions by the Department of Ag for food insecurity. So we have embedded those, and as patients are roomed or come into the clinic for a visit, they're asked those questions, or we also will identify populations and push those questions out electronically. If they answer yes to either of the 2 questions that are on there to indicate that they do have food insecurity, then they're referred into the program.
Okay, and what is the fresh food pharmacy?
So the fresh food pharmacy is it's essentially a partnership with the Central Pennsylvania Food Bank, and we have taken a food bank concept, but we've made it a clinical model. So on our hospital campus in one of the counties, again, that I mentioned has high prevalence of food insecurity and high rate of type 2 diabetes, we actually built a pharmacy. It's a little less than 3,000 square feet. It includes a warehouse that has the food. It has refrigerators, freezers. It has a conference room for us to do the classes, a registered dietitian office, a community health office. So it's when people think of a food bank or a food pantry in a hospital, they may think of a repurposed exam room somewhere that has some emergency food services. That's not what this is. This is a food program that provides food for a patient and their family for 5 days a week, 2 meals a day, so 10 meals a week, which is pretty significant. They can come in every week. And the food pantry is sourced with all fresh fruits and vegetables, lean meats, whole grains, very diabetes appropriate types of food. And so our participants, when they enroll in the program, they participate with their care team. They do education classes. They meet with a registered dietitian. They can participate in cooking education and demos and things like that. And then they also get the food provided to them as well.
And are you seeing a difference from this effort?
We're seeing huge clinical impact. We've seen, on average, about a 2-point reduction in hemoglobin A1C, which most medications will tout success with a 1-point reduction. So we're seeing about 2-point reduction. In some cases, we have patients that go from a 13 to a 6, which is a huge reduction in hemoglobin A1C and decrease in medications. The other thing that we're seeing is that there's other clinical measures that are also showing success. So while people are reducing their hemoglobin A1C because they've changed their diet, they're also reducing their LDL, their triglycerides, their blood pressure, they're losing weight. So all of these other health measures are additionally performing well. And we're also seeing a higher prevalence of care gaps being closed for the patients who are participating in the program. So they're more likely to get their eye exams, their foot exams, and some of these other preventive measures that need to be completed.
And are you finding that, are you having people follow up too after, I mean, does the food pharmacy end after a certain period for these people and then they're on their own, or how long does it last for them?
That's a great question. So the program is available as long as people need it. And so sometimes that's a little bit challenging for people to wrap their arms around because we have people who have been in the program for over a year. Our philosophy is if the food is what's keeping their healthcare costs down, and we would rather see the long-term impact of their healthcare costs being down, the food is not the expensive part of the program. And it costs us anywhere from $1,200 to $1,500 per year to feed a family of 4 in this program. So the food is very, very economical. So it's high intensity for about the first 6 months of the program as far as clinical care, education resources. And then after that, there's additional supplemental education resources. We have a lot of our participants that want additional programming, so they'll ask for weight loss programs. Now that they've started losing weight, they're more engaged and they want additional programming around weight loss. They'll ask for tobacco cessation programs or other programs. We have a community health assistant who works with our patients to make sure that they're taking advantage of their SNAP benefits or other benefits that are available to them to try and help supplement and get them on the right track. But the goal of the program is to be able to have patients be more independent, but it takes that full wrap service for, we feel, about a 6-month time frame, really, and then possibly the continued support of the food if they still have access issues or are still food insecure.
All right. Allison Hess, thank you so much for sharing that. We appreciate it.
Yeah, thank you for having me.
And I'm Mabel Jong. Thank you for sticking with us. Stay tuned. Much more to come.